so we are now recording. I'm going to minimize that. Please feel free that y'all are like I said, more than welcome to unmute and talk if you guys have questions. All right, so again, I told y'all we were changing tonight. So we're going to do principles of pharmacology. So I'm going to try to make it as fun as we can. We're going to have a good time. All right, so pharmacology. So this applies to the patient assessment and management fundamental knowledge of the medications carried by AEMTs that may be administered to a patient during an emergency. So understand when we start talking about pharmacology. So remember, I told y'all to begin with that you are going to be on a national EMS, like kind of a standard. So I'm just going to use just for example. So let's say one particular group is able to carry epi and the other one is not. The reason why is because your protocol don't allow that. So when you are currently working in your position, if you're working on a truck or fire truck or whatever, make sure that you're aware of what your current agency's protocols are. So that way, when we do talk about medications and all that, that you are aware of the medications that you're able to carry, because in different regions, we're not going to be able to have some of the same medicines. But again, we're going to talk on the national level. So when we start going over certain ones, we're kind of understanding the basics of pharmacology. Just wanted to get that out there. All right, so here's everything we're going to talk about. We're going to talk about medication safety, kinds of medicines used during an emergency, the legislation, some naming, classification, storage, and security. Autonomic pharmacology, metabolism, and excretion mechanisms of action, medication response relationships, medication interactions, and some toxicity of it. So I know y'all are excited, so let's get ready to dive off. All right, so administration. Medications is very serious when we start talking about providing medications for certain things. We, as advances, we need to make sure that we understand how it's going to take place. So medication is, we have to make sure that it's used appropriately. The medications may relieve some pain to improve our patient's well-being if giving correctly. If we use it inappropriately, we're gonna potentially have a lot of issues. Patients, a lot of times when they say they have reactions to medicines, I've always asked, well, what kind of reactions do you have? Well, morphine makes me itch. Well, that's a side effect, not a reaction. So, like prime example, like myself, codeine makes me have full body cramps. So that is not a side effect, that is a reaction because codeine is not supposed to do that. So I'm weird. We all know that. So that is one of those things that I have to mark that. And penicillin, I can't take penicillin because it makes me quit breathing and I'm addicted to that. So we don't want to do that. So as an advance, we need to make sure that we know administering certain medications to our patients. We need to know what medication. There's some 5 R's that I will go over a little while. We need to make sure that we help patients self-administer some of their own medications. We still can assist in giving some, like an EpiPen if the patient has that, their own inhalers. So it's not saying that, well, we're back at the basic level, we can't do this, but we can help them administer some of the other ones. We still need to document that we use this at this particular time and all that. We need to make sure that we know what type of medication allergies these patients have, and that is going to be built into doing a very good patient assessment. Now, once we get this information, you all know, as basics and all that, we listen to our crew members give reports, doing the handoff notifications and all that to the hospital or the receiving facility, allowing them to understand what allergies they have, what situation the patient's in, what medications you've given, and what timing is very important, because they're going to ask those same questions, but we need to make sure that they're aware of it to begin with. And no matter what, it's going to happen. It doesn't matter what you do, but the patients are going to tell the receiving facility some different information. I don't care how good of a report you give or how hard you dive off into a patient's history. They are going to just give information differently, and you're going to be like, huh, you didn't tell me that. I appreciate that information. So if you hear that, and just note that that's part of being in the EMS system. All right, so as an advance, we who do not understand how medications work themselves and their patients in danger. I don't know what that sentence is. AMTs who do not understand how medications work there needs to be a comma there, place themselves and their patients in danger. All right. So a drug profile gives all of the specific about a drug. So when you get a medication and it comes with a little packet of information that's all folded up, or the pharmacy gives you some information, I can guarantee you that 99% of y'all throw that away. I don't read it. I don't read mine. But a lot of people do take the time and read that. And what's going to stick out to them is all of the side effects, the contraindications. And again, that's important when we give medications. We need to particularly know what type of information, what medical history they have, and is there a particular medication that they're already taking that may give them a contraindication for providing that medicine. All right, so also listed in your various pharmaceutical publications of that profile, and when you talking about the drug profile itself, we need to make sure that you start to familiarize with those particular drug profiles uh, that you are expected to administer during your time as an advance. So knowing the ins and outs and the who's, what, when, where's, and why's of the medicine that's in your bag is very, very important. In your book, you should be able to see on 12.1, and again, the chapters may be off, so I apologize, but it's what my slide says. That's going to give you some of the components of that particular drug profile. All right, so drug terminology. So pharmacology is the study of properties. Now, when we say properties, remember that's also the characteristics of effects of drug and medications on the body. So when we start to give those characteristics, we need to know pain medicines. What are they doing? They're hiding the receptors. They're kind of closing those. Now, I'll tell you this: like not too long ago, I was in the hospital, and morphine is a smooth muscle agitator. So when I received the morphine as for pain relief, it actually triggered that worse. And I really, in the situation, I did not understand what was going on until it just clicked in my head what was going on. And I told the nurse, I was like, hey, I got to have something different because this is not working. This is creating it worse. And I actually knew the nurse very well. And she was like, oh my God, you're right. I am not, by no means, I hate pain medicine and all that. But that particular event, I was all about some fentanyl. When they gave me that, I thought the world was amazing. All right. So let me get off of this. So drugs. So we talk about chemical agents that are used in diagnosing, treatments, and prevention of disease. So when we say disease, it may be particularly related to what's going on with this person. The term drug and medications are often used interchangeably. So when you see this as we go through, know that we may be talking about different things. The same thing in different times. However, drugs may make some people think of illegal substances. And when we talk about giving fentanyl, when I do that a lot of times at work, people are like, "Oh, I don't want that." It's a medically approved fentanyl usage. I am not just using some street fentanyl to give you anything that it's laced with. So I have to know the particular patient's weight, size, and all that, so I can go along with what my protocols say on administering of a pain medicine. So you need to make sure that you should use the word medications when you're talking to elderly, family, and all that, because when you say, all right, I'm going to give you a drug, they don't, those interactions, people use more of the worst side of things versus understanding that I'm going to give you some medicine that's going to particularly help with ... So a medication is a chemical substance that is to help relieve pain or prevent any other type of disease, illness. Like if we give an antibiotic, we're fighting on particularly what's going on. So knowing that, we need to make sure that we get those informations. Are we about... Stand by. I see somebody put something in chat. I just have to open it to see it now. Stephen, how are we about... How are we going about logging into...
He was in the EMT room, but he's in now.
All right, good deal. Thank you. I appreciate you that. You must have helped him out.
Yeah, I sent him an invite.
Oh, that was nice of you. All right, make sure that shows back up. All right. Whoops, come on, slide. All right, there we go. Now, we talk about dose. Well, we have to give the medical correct dosage of a medication. So dose is the amount of medication that is given that depends on our patient's size, their age, whether the patient is an adult and or child, and what is our desired action of this particular mean. So we want to know, are we using a particular medication for, let's say, respiratory sedation? If we're going to try to sedate somebody as a medic, I can give certain medications versus I can give it for a respiratory reason, where if I want to snow them under so I can intubate and not have any issues, or I can give that same medication in a therapeutic range to not snow them under. So I have to be able to know what the desired action is. As you see there on your screen, it says action, therapeutic effect, or intended effect that a medication is expected to have on the body. So knowing that information is going to be very beneficial to us. Stand by real quick. Sorry, I was having to answer my child. All right. So understanding the unintended effects of our medications, we need to know that the effects are undesirable, but they do pose a little bit of risk of the patient. Like Benadryl. If I give too much Benadryl, I'm going to create them to go to sleep. Well, I don't want them to be going. I don't want that to happen. That is a side effect. So being able to give that medication for a reaction is important because we need that. So we need to know that is an unattended situation that's going to take place, but we know that is also potential part of that medication that's going to make us sleepy. So the untoward effects is effects that can be harmful to the patient. And remember, we don't want to cause any harm whatsoever to our patients. That is making sure that we give the right medicine at the right time, and it is the correct medicine. Toxicity is the risk of that a substance will pose a health hazard to an individual or organism. So you can have medication toxicity if you're taking too much. Like if you give two medicines together, let's say a patient has a cardiologist that gives them a lot of medicines, and then we turn over, we go to a respiratory doctor, and they give another type of medicine. Well, now those medicines react against each other, and it's creating a toxicity. I hate it, but these physicians don't really talk back and forth with each other. They're fighting issues that are going on in their own lane. And I get that. I understand. But it's bad for the patient. So sometimes we're caught in the middle of that. So I don't expect you to understand all the medicines out there, because trust me, man, I don't understand all of them. There's a lot of times I'm like, hang on, bro, let me Google this. And Google's my best friend. I've learned it. I use Pill ID a lot of times when I'm trying to figure out who's taking what's being done. A lot of that is just because I need to know so I can educate myself. and also potentially educate my patient. Because remember, we're not going to see these patients in a general setting. We're going to see them at their worst time. So having that information relatively available can be electronically on your phone, but we need to have a vast knowledge of what's all out there for our patients to be taking, and kind of understand. The more that you're out on the streets and you see these medications, it's going to help. And if you're currently in a situation to where you can have your partner or write some of those medicines down, go back to the station, discuss it with your partner, or even do your own little research. Okay, what is this medicine for? What is, what is the potential use of that medicine? Will help you prepare for things that are going on currently and future. So indications. So indications is the therapeutic use of that particular medicine. So that's what we want. We want to be able to use medicines for their intended use. So contraindications. Now, contraindications are times when you should not give a patient a medicine, even if it is usually indicated for that person's condition. So a medication is a contraindicated when it would harm the patient or have no positive effect on the patient's outcome. The biggest one I like to say here in this situation is nitro. When nitro works great, we know what it does. Sublingual and or the spray, man, they do their job, but sometimes we can't give that medicine because maybe we don't have that IV access just yet. I never give a medication until I have an IV established. I may have orders for it. I can do it either IM or I can do sub-Q, but I don't like to give any medicines until I establish a very good patent IV. I've been bitten in the butt too many times by that. That's just a personal thing. So keep that in the back of your mind. Is you're going to work that chest pain. What is yours? What's your plan of action? Do I need to do this, or this? Do we have to do certain things so we know? Hey, if things do go south, I have a good IV. I can start, give a medicine, or can I bolus them, 200 or 300 cc's of a normal saline or LR to help us out in a situation. All right, so drug names. Here comes the fun stuff. So drugs we use are diverted from principal sources. So here we talk about animals. So insulin is usually prepared from the pancreas of an animal, primarily pigs. So vegetables, plant sources, we have roots, leaves, flower, and seeds. We talk about minerals. We talk about calcium, iron, magnesium, some of the things that we see over the counter. Synthetic compounds, drugs manufactured synthetically where they're made in a lab. Synthetic forms of vitamins, steroid, narcotics, etc., like that. Like prime example, here's one for you. How many people do you know that are allergic to feathers? Like you can't have down anywhere around them. Do y'all know anybody that's like that? Or eggs or anything like that? Well, if you don't, or if you do, you know that that person cannot take the flu shot because that is a synthetic medication that is made that actually has that in there. So if they have those, they cannot take the flu shot because of what is inside of the synthetic made drug. I'm full of useless knowledge, but one day that'll come in handy for you. All right, so the trade name. Brand name a manufacturer gives to a particular medicine, like Tylenol or Lasix. Those are your brand names. Now, proper nouns that begin with a capital letter. This is where it gets important. So one drug may have more than one trade name, depending on particularly on how many companies manufacture it. A generic name is usually the original chemical name of a particular medication, like ibuprofen. Usually suggested by the first manufacturer and approved by the FDA. That's how it sticks. Some medications are called by their generic name more often than their trade name, like nitroglycerin. That's just the generic name for it. Because if we had to use their trade name, I'd be in a problem because I probably can't pronounce it. So all medications licensed to be used inside the U.S. are listed by their generic names inside of the United States Pharmacopeia. I used to keep a subscription to that, and they would send out a new book every time, but that book is like 7,000 pages. It's a great thing to have, but they make them in an app now that is so much easier. Okay, sorry. I'm getting the basic Teams notifications also, so I have to go back and forth, see who's doing what. So chemical name. So this is a very precise description of the medication's chemical composition and its molecular structure. The official name, the name is that is assigned to a medication by the USP. And then usually the generic name followed by the USP. You'll see when we get a little bit further, we'll start breaking that out. All right, so here comes the fun part. So you see right here where it says chemical name. Bruh, I don't know what all that means. I couldn't tell you. Like, is this 11 Bravo or is that 11? Who knows if that's a B and a P? So the chemical name right there. Now we talk about a generic name. It's the beclomethacine dipropionate or Vanseril. Now we are used to seeing that trade name for Vanseril. Now the official name is the beclamine thiazone dipropionate that's given by the USP. And there y'all can tell that I don't pronounce them right, so I'm sorry. So do you notice the difference there? So look at the trade name is capitalized and the official name is lowercase. Those are important when you're writing medicines or typing in them in your report, adding the capitals versus the lower, because we're either talking about its particular trade name or its generic name. Even on your medications, you will see that when you get them from the pharmacy, they're either capitalized or lowercase. It's just built into the system because they need to make sure that they're using the proper name of that medication. Prescription medications are distributed by pharmacists according to a particular physician's orders. A lot of times, I gotta read this one because I know y'all making fun of me here. Thank God being able to pronounce it. Yes, that is, and they won't test you. Don't worry, Lindsay. National Registry is not going to test you on how to pronounce them correctly, so don't feel bad. Because if so, I wouldn't have made it. Wouldn't have made it at all. All right, so over-the-counter meds. Let me back this up. So when you take either a prescription to the pharmacy, or they call in one, like prime example, some narcotics, they cannot send that electronic. You physically have to take that in. I'll tell you, I'm on Adderall. I cannot take my prescription. I have to take a physical prescription in versus them sending one in for that particular medicine. That's just what they mandate here in the state of Mississippi. Some other places may be able to do that. So the over-the-counter, yes, that is any control. So yes, that is correct. So what she was, or I don't remember who said that, but any control medicine has to be a physical script. That is just the way it is. So sometimes we may get frustrated. We're like, why do I have to go by? We are the 21st century. Why can't they send it? That's just part of the regulations. So OTC medications may be purchased directly without any prescription. Now, when we talk about, so in the United States, let's put it that way, you can go get the over-the-counter medicines. Yeah, they may work as well, but some of them may not work as good as the prescription itself. Other countries, you don't have to do that. Other countries, you can literally walk in a store and buy whatever you want. So is that good or is it not? That's that country's particular issues there. Many problems attribute to a prescription medication may become more common as the drugs become more available for over-the-counter. You may also encounter a patient who have taken some street drugs, obviously like heroin, cocaine, all the other fun stuff out there. obviously we know that street drugs do lack that purity of being an over-the-counter medicine or a prescribed medication. It is made in somebody's nasty kitchen. They are, I will say, they're not stupid people. They are smart when it comes down to them making. I didn't say they made some of the best decisions, but I just don't want to put some of that in my body. Now those street drugs, they still have that pharmacology active, um, but will cause an effect. So we know, like cocaine, some people it just gives them that speed, that rush, that just go 3 days in a row, and then some people it's like, man, it just chills me out. It gives me that rush, and then I'm just like, there's other ones out there that acid, all those things that they have those desired effects. It's just I'm not real sure who made it. You may get Billy Bob to make one a part of it, and then you might get Fred that knows what he's doing. It's there's no consistency of any type of street drug. That's why we have those different reactions because of the purityness. You like that? That's a new word for me. All right, so some sources of drug information. There's several different references out there. You have your American Medical Association of Drug Evaluations. You may hear them as the AMA. The Physician's Desk Reference, that is a great book. The Nurses, I think I used to have one when I was going through medic school. The Nurses Pill Bible was a really good Bible, really good book to have because it wasn't super thick, but it broke it down to where I was like, all right, I got it. You have your hospital formulary with what's that say? Local publication that uh, delineates which drugs are used in a particular facility. Okay, I'm not used to that one. We talked about those drug inserts. Those are the ones that are packed in the medicines that none of us read. This includes information related to how it's prepped, the particular dosages, what effects, what side effects, and some other information that could be potentially important. Um, a lot of times they will put information on those bottles like do not take medication and drive, do not take medication and be in the sun because you're going to get a lot of that's your antibiotics. You're going to get um, you're just going to get more, you have the blotchiness to you and you're going to have a sunburn there. There are numerous other texts and sources, including of the internet. We talked about that. But as an advance, you should be familiar with the sources and some field references, particularly regarding the medications that we encounter in the pre-hospital setting. I, again, have not done it in a long time, but I used to keep a field guide on me 24/7. I had it broke down to I had my little tabs in there. They were color coded for certain medications that I could open up and say, okay, yes, I know this one. Da, da, da. And plus, it gave me the ability to be able to spell it right until I learned more of the proper abbreviation, the proper how to note it in a report. So I'm a huge fan of field guides. So if you have one or find one, I highly recommend in getting it and keep it on you. All right, so our U.S. regulation of pharmaceuticals, that has been in a question a lot here. Currently, I don't have a field guide, but I will post some information here in a little while. Of some good ones. I will get that information because I do have a list of them. All right, so the manufacture of pharmaceuticals in the U.S. are most other countries is some subject to variety of laws and regulations. That's why we can't get certain medications in the U.S. and that's why we have some medications that other countries can't. It is intended to protect us as consumers. It does prohibit manufacturers from making false claims about the benefits of their particular drug. There are some regulations that they follow. As we know, my favorite conversation one is about the COVID vaccine. You have all these different things, and you have lot numbers, and now they're having all these issues with lot numbers, and certain ones got these effects, and there was a lot of red tape bypassed, as we all can shake and say and have different conversations about that. So it does outline a particular standard for a drug manufacturer to ensure that that drug that is produced by different manufacturers that has that uniformly strength and the purity. So if two different companies, company A and company B, are making ibuprofen, they have to be able to follow certain guidelines, certain rules that keep them making the drug the same across the board. It may be circular, it could be oval, but no matter what, we know that it's 200 milligrams of ibuprofen in each package, as long as it's bought inside the United States. So drug standards are published by the USP and the National Formulary. There are several federal laws that have been enacted to protect us as patients for some unsafe substances and unscrupulous manufacturers and distributors. So the FDA puts that out there. There's a lot of medications that we even use on a daily basis that is not particularly FDA approved. Like morphine. Morphine's one that's been around forever. It's still not FDA approved, but we use it all the time. We use these medications for its intended use, and it does a great job. Is it abused? Every medication that we have in the world has a potential use for being improperly used. We know that some people get addicted to medicines. Well, they all have those unforeseen side effects, those wants of patients that strive for that. So that's why there's a lot of medications that are strictly regulated. We have to follow certain procedures with those medicines. So drug-related legislation. So we have the Pure Food and Drug Act of 1906. You will see some of these questions, and when they ask about like, what are some drug-related legislations, as in asking, make sure that you know the Food and Drug Act has 1906 versus 1996. So that's where you want to make sure that you know the years of them. So that act was first federally drug-related legislation in the U.S. So that is the first time in 1906 that they made this legislation to move forward to where we are today. It was initially aimed to protecting the public from food, medications, and alcoholic beverages that may be mislabeled. They could have some poisonous to them, that toxicity, or they were just otherwise harmful to the people. They started an agency to where they knew that they could check these drugs and make sure that they were not harmful in any means. So you have the Food, Drug, and Cosmetic Act of 1938. This one it's constantly being amended. So, and 52 and 62, it was amended to where we are. And I want to say there's a newer amendment. I looked not too long ago. So this does require drug makers to label their products, indicating warnings about possible side effects. So that's the reason why if you buy a pack of cigarettes in another country, you will actually see pictures of a diseased lung versus a clean, healthy one. That's what they allow to put that on there. In the U.S., I couldn't tell you the last time I held a pack of cigarettes, but I think there's a warning label on there that tells you this is harmful and da 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 da. So it is a requirement that those get put on there. It is authorized the creation of the FDA, and it did mandate the dangerous drugs that could be dispensed only with a prescription, as we've talked about, we've all at least seen. And that's where you see some of the Cosmetic Act that they may not put on the particular one, but they may have, some animal contents or animal fat in certain parts, certain things that are beauty products, or if it was lab tested on this or that. They won't go on that particular the cosmetic part, but it has to be on a very reliable researchable part of their website on how that chemically is made for a cosmetic part. All right, so we talked about the Harrison Narcotic Act in 1914. This did start to regulate the important manufacture, prescription, and sale of several non-narcotic drugs and cocaine, opium, and their derivatives. Obviously, before this, that's how Coke got their name, because we all know that in the beginning, Coke had cocaine in it. Sometimes it'd be nice to have an original Coke bottle. But all right, so it did require some precise recordings of them when they had to dispense these controlled substances. Like prime example, do you know state of Alabama leads the nation in the prescription of narcotics in the world? They prescribe more narcotics to their citizens of the Isle of Alabama than anywhere else in the world. That just blows my mind. I mean, there's a huge agency within Alabama that regulates that, but they're still not wrangling in those issues. Let's see here. Required registration of distributors such as pharmacies. So you can't have the I call them the stop and rob pharmacies. You can't have those anymore. They found a couple of years ago there was one on the coast that was run by a bunch of Orientals, that they were running a stop and rob pharmacy in the back of their store. So that's where a lot of that is controlled. You have your Narcotic Act of 1956. It did increase the penalties when they started to violate that Harrison Narcotic Act. That's where your ATF and all these started to come from, because of the alcohol, the prohibition, and all that stuff. They had to have these acts come around, and it did make at this particular act, heroin was illegal to have, and it outlawed the acquisition and transportation of marijuana. Now, again, y'all understand that it is federally illegal to possess marijuana. Some states have a open sale of it. You have to have a medical marijuana card. But again, it is unless you take side roads and back roads and all that, if you get pulled over on a federally funded highway, that is still can be a federal offense. The transportation of it, all that stuff is different state by state. I can specifically speak for the state of Mississippi. There are a few of them that are popping up around my area, but they say that it's mandated and controlled by the state and all these things. But again, you can't get on uh, a airplane and take one from Colorado to Mississippi because it's illegal. They're federally, and the Federal Airways, they're controlled by a lot of the feds when they start talking about that. So be cautious. Sometimes you may go to a trip and do you, but if you attempt to forget that you packed some, you can potentially looking at some federal charges. All right, so the Controlled Substance Act of 1970. This is a comprehensive legislation dealing with narcotic and non-narcotic drugs that have a potential for abuse. Some of the specified requirements for is registration, procurement, how they are stored, even how they were distributed, and then the records of these drugs. Now, 99% of your states all do electronic versions, so it's still tracked. The Bureau of Narcotics, the MBN here in the state of Mississippi, there is a website that they can have access to. If I'm particular, let's say if I'm doctor shopping, they can see how many prescriptions I've acquired and who issued those. So a lot of states have that. It's an electronic thing, and that's when you may get a knock on your door. And then the penalties for failure to comply with these requirements were drastically increased. And then some of the drugs that are covered are classified into 5 categories or schedules according to their abuse potential. Please make sure that you take note of this. So a Schedule 1 drug has the highest abuse potential and a propensity for a severe drug dependence. It is completely outlawed on rare occasions under the control of the FDA and Drug Enforcement Agency, the DEA. These drugs may be used only for research, analysis, and instruction only. I'll give y'all an example. University of Mississippi up in Oxford, Ole Miss, if y'all want to say, U of M, they're go Rebels. Woohoo. Um, they have the largest in the country federally funded marijuana farm to do research on the THC, all of that. It's right here in the state of Mississippi. So a Schedule 4 includes drugs with the lowest abuse potential. You should find in your book there's going to be a list of the different schedules, the 1, 2, 3, and 4, that lay them out and shows some of the descriptions and examples. If the state law is more stringent than the federal law, the state law takes precedence. As an advance, you should be aware of the laws that are in your particular state and follow those local protocols that are put out there for you. Um, I've always said that even it don't matter who I get, in the back of my truck, I always tell them, listen, man, I don't care. It doesn't bother me. I just need to know, are you on any type of street drug that potentially can cause a side effect to a medication that I'm fixing to give you? A couple of times people have been very, very honest. And then there was this one time I'm going to University Medical Center and this guy pulls out a straight solid brick of weed from the strap to his leg and be like, yeah, I got some weed on me. I'm like, I've held bricks of weed before, but I'm like, how how am I what am I supposed to do with this in the back of the ambulance? Because that is a state run facility. So if he was got there and they did a pat down search, he would have been charged for it. And I'm like, uh, yeah, I told the officers once we got there, I was like, hey man, this dude just dumped like a brick of weed in my ambulance. I don't know what to do with it. What they did is what's on them. I just sometimes it helps to inform your patients of things and how things work, so it can help you know if there's any type of illicit drug in there. Just that's just how Chris ran it. All right, so manufacturing related regulations. So the federal legislation also focus on guarantees some of those standardizations of your dosages. Standardization assures patients when they take a medication with a stated amount of an active ingredient that they will receive that stated amount of that drug. So for a drug to carry a USP label, the amount of an active ingredient must be within that 95 to 105% of the label that is on there. So there is still some variancy there that you see. Now that's a pretty wide 10% in my mind, but when you think 10% of 200 milligram ibuprofen, that's within range in my opinion. I'm good with that. So I'm okay with not having a point 0 or 0.01 difference in 200 milligrams because that's pretty stringent. So when they test these. All right, so the government agencies that regulate the drugs, you have your FDA, which is your Food and Drug Administration. They enforce the Food and Drug and the Cosmetic Act. And then it does determine the safety and the efficiency of those drugs before they are allowed to enter the U.S. market. The DEA, or the Drug Enforcement Administration, it is formerly known as the Bureau of Narcotics and Dangerous Drugs. This was created by a Federal Controlled Substance Act of 1970, and this is a particular division of the Justice Department. They're responsible for executing provisions of the Controlled Substance Act, which include regulation of physicians who are permitted to dispense controlled substances. You have your public health service. They are part of the biologic products that are medications made from those living organisms, and that includes antitoxins and vaccines. Sounds like somebody really wasn't checked on when they were doing the vaccines. So the Federal Trade Commissions, or the FTC, they monitor the drug advertising to make sure that those drug advertisements aren't misleading or just plain out inappropriate. They do make recommendations to the FDA regarding the direct-to-consumer advertisements. They found that direct-to-consumer advertisements generally benefit the consumers, but its stated ads should contain a major statement of the drug risk with the adequate provision of more complete risk information. So when we see these informations that are out there and they put on TV, they are regulated and they have certain availability to advertise that. Now, they're going to make sure that they put that in all of the information in that little drug packet, but they may give you some variance information of when they give the commercials. They can't be misleading, but it's going to make sure that it benefits you, like you're going to be like the Madura. We'll talk about that medicine. So it doesn't tell you that it has a weight loss potential, but it tells you about it's going to help control your diabetes and your A1C and all this. But a lot of people are using it for the weight loss side. They're not misleading, they're just not telling you what are some of the side effects of that particular medicine or some of the effects of that medicine. I show like 8 more minutes and we'll take a break. I know it's hour for hour, but I'm going off of the clock that's on my computer. All right, so the drug approved process. So there's new drugs that are constantly being developed. We don't hear about them. We don't see them until they come out and you're like, what is this? So trying to stay up on all these medicines that are put out is almost impossible, but it's nice to know what a lot of these medicines are. So the commercialization process takes years and years to process. Let's say like a cancer medicine that's been in research for 10 plus years, and you're like, why hadn't we had this medicine? Well, it's under regulation for them to be able to produce this. So what is coming out now in 24, 23? Sorry, it is 24. Started in 14. So you have time. They have to try this medicine. They have to put it out there. They have to test it. Has to get approval. It's a lot of time. In some cases, those manufacturers find out that the drug does not work and like in it's envisioned, or it's just too dangerous for us to take. All the new drugs must go through animal studies and clinical trials and humans to be approval for distribution. So that's where you see some of these places are like, get paid to take a medication. That's where they give you the placebo pill versus the real one, to where you they have to do that controlled study. Animal studies. Now, this is designed to learn more about the properties of a particular drug, and it identifies the tissues and organs that are sensitive to that drug. So a lot of times you hear, unfortunately, you have your mice, monkey, pigs. That's what they're tested on because they have the same structures, the organs, how everything works on them versus us. I'm not a fan of animal tested medications, but at the same time is I'm really sure we're not going to get approval for, caged humans in drug testing. It's probably not going to happen. So unfortunately it is up to the animals. So those testing that has to be done in at least 2 of those animal species, that is required by law. So before it gets out there, you at least know that the monkey and the pig had it and they probably survived. So that's how we get that medicine. There's some that didn't make it because they were still trying to hone in on the particular on how the medicines work. So after some successful tests, some testing studies, investigation of that new drug and their clinical trials, then it's breaks into the human world. What can humans do? I mean, the use of that. So these trials are needed. They're needed for these animals to help us in the human side. I'm just not a fan of them testing on the animals. I guess you can say I'm an animal guy, but I don't really like that particular use. All right, so here's parts of the drug trials. So phase 1, the new drug is tested in a healthy volunteers to compare human data with with those 2 different types of animal species. It does determine if the drug dosage is safe. It assesses the medication safety. So all this information, they collect it, they compile it, and they start studying it. Phase 2 is performed in certain populations. How do you pronounce that? Homogeneous. homogen. Yeah, that. It's anywhere between 50 to 300 patients of that particular study. So when they ask people to make a living in testing drugs, it's not my cup of tea because I don't need to grow an extra arm to see if it works. I don't know. I don't want to try that. But it has to have that double-blinded study. So one group of the receives the particular drugs and the other receives that placebo, like I was talking earlier. It is designed to evaluate the efficiency and the safety of their drug. It does establish which form is the most effective dose. So they have to get these clinical trials. Then they want to know, we tell you what the medicine does. Does more of the patients that receive that placebo, do they mentally think that's what they're getting and they improve? Or is it, the people that are getting the particular medicine, how are they received? They may be not told what all the medicine does. They just need to reply with some information on what's being, how they feel and all that. Phase 3. So the drug is made available to a larger group of patients. We talk about several thousands of patients then. These studies usually last several years. Again, they evaluate the efficiency of that drug. They monitor the nature and incidence of those particular side effects of that medicine itself. And then phase 4, the company developing the drug now applies to the FDA for them to approve it or reject it. It has to fall into their categories. They have teams of scientists, biologists, whatever, to compile that information. When they read all the compiled information, provides them better information to where they say, okay, yes, well, this particular group, FDA marks it, say we're good for it. The other group may have questions, so they have to see if it's really going to do what it does. Now, they also compare it to some of the other drugs that are on the market to see if I don't want to say they stole some information, but is there other medications out there like it, and does it work? Prime example, one of the medications I'm on for migraines, it is now finally being made in generic. So my insurance obviously is wanting to fight that and me to go generic, and I get that. But the generic does not have the same dosage versus what the original has. So it took a while for that generic to come out. Let's see. Then they examine the drugs for their long-term efficiency and what is the particular cost efficiency. Now, like prime example, your epinephrine. We know that an insulin, those are made very dry. I mean, they're all out there, but why is it so high? My thing is, if I don't have insurance, but I gotta have insulin, I can't afford it because it's so high. Well, they're supposed to look at that and see if they can help lower the cost, but there's a lot of regulations out there on what they can and what they can't. It's a frustrating thing when you dive off into it to see exactly how it's done and what it's done. I show us right at an hour here. Let's take a break. Let's do 15 minutes if you guys don't mind. I'm gonna try to scarf some food down. So I show that would put us at 7:25. Let's come back and we'll keep going. Don't have too many slides left, but we'll get it knocked out, and we'll see y'all back in just a few minutes. All right, so I don't know if my clock's a little fast or not, but I show time. So, all right, let's get this to working now. All right, so on the drug storage and security. So even being offshore, we still have to fall under the FDA and the requirements that they do. So you have to have narcotics technically locked behind two locked doors, locked or two lockable mechanisms. So that's one of those that we have to make sure that we require. So now, all drug containers or boxes should be carefully guarded against some possible theft. We know it happens. We know we have crews that once the people and drug, they find out that they have those on them or have they required. So they are required to be locked, secured within the ambulance at all time. We used to carry them on us. I remember the day I used to carry them in my pocket. I had a like an old travel toothbrush container that I kept my narcotics in. Now they have to be locked inside the ambulance. Certain precepts should be guide the manner in which these drugs are secured, stored, distributed, and accounted for. That's the reason why when you give a narcotic, you have to have like the patient ID, the report number, the date, the time, what was administered, how much, and then if you have to have any type of witnessed, like if you're trying to get rid of some medications that's left over, all that has to be accounted for. Again, please make sure that you're familiar in what is in your local protocols, and make sure that that is always documented, and you follow those first. If a controlled substance, such as a narcotic, is administered, the records may be kept separate from some other paperwork. Electronically wise, they can go in there and have those pulled, or once it's certain keystrokes or it's coded a certain way on the back end, they may send that paperwork there. The DEA can come in and inspect those paperworks at any particular time. If you're on shift and you go to check your narcotics, at the beginning of the shift, you account for, let's just say, 4. As you go through the rest of your day, you open up your box to give something, and now you have 3. You immediately need to notify your chain of command, because a law enforcement has to come out and do a report. I'm sure that you would be sent for some, like a drug screen or something like that to make sure, and that's all for your safety. But that has to be taken care of, because the FDA or the DEA can come in and be like, okay, what happened to vial number 0017? They need to know that. All right, so all medications should be stored in a temperature controlled environment. We know if they're left in ambulances and they're not stored inside of a warehouse, that is not, it's just kept in a parking lot, that can be bad. Certain medications are affected by the temperature, light, moisture, shelf life, exposure to air, like nitroglycerin. That's the reason why that's in a tinted glass bottle, or a kind of I call it a rust color, is because the lights will break it down. The movement of those pills in there, they become dusty. That dust can cause some adverse effects to you as a provider. If a controlled medications are not used before their expiration dates, they have to be destroyed. A lot of your EMS schools will get the expired, like the medication's been wasted, but they'll have like the epi, syringe that's been emptied, and they clean them out and they can use them. So you can say, I'm giving, epi at such, so you're used to having to go through the box, grab the right ones, color coded, all that stuff. So you can do that, but there's a process before they make it to you. So if you're ever having to be in a position to where you have to get rid of some medication because of expiration or whatever else, be sure that as you CYA is you have somebody else witness it with you. If there's any type of particular paperwork that your agency requires, or some form or anything like that, make sure that both of you sign it saying, we wasted this medication on this date. I kind of write a little narrative if I have to do that, even if I do it offshore, or if I don't give all of my narcotic. I don't have to have somebody witness it, but we still have narcotic waste forms. And that is I always do that. I take it to our rig manager and I tell him what I have. I show him what I used, and then he witnesses me disposing of it. And then I just have him sign somewhere on the sheet saying, witnessed by on this date at this time, and what medication it was. So that's just, and I know when I draw my medicine up that, how do they know? But again, I get drug tested more than you can imagine, going to and from and all that, even at home. So I'm not going to be using it, but it's just, I want to cover myself, because I'm the only one out there that technically can look at this medicine, pull it out, check it. I just want to be covered. Some special considerations in our drug therapy. Obviously, pregnant patients, before you administer medication to a female of childbearing age, make sure that we need to know, is there a possibility that they could be pregnant? Now, granted, I know if they're of childbearing age, we always have to take it saying, we just say, if you're of childbearing age, there's always a potential chance that you could be pregnant. In an emergency situation, we know that the women's health is the top priority. So we may not ask that particular question in an emergency. But before we administer any type of a drug or medication or anything to a woman, we need to know what the expected benefit should be, considering against what is the possible risk to the potential child. So we need to be aware. We need to know that drug, be like, all right, this is what I need it to do. So that's where you want to make sure that your correct dosage is administered, and not be like, well, that looks like it's 2.5 cc's. It might be 2.8. So we just need to make sure we know those back there. All right, so prescription and OTC drugs have a potential to harm the fetus or a newborn. Tetragenetic drugs, a drug that poses the risk of the normal development of a health of the unborn fetus. The changes in a pregnant woman's body affects the way that the drugs are processed, and they may increase a chance and harming of that fetus. The metabolism of a drug is in the liver is decreased during pregnancy. Increased rate of excretion owing into increased cardiac output during the pregnancy. Now, the FDA has established a scale of categories A, B, C, or D, and X to indicate drugs that have documented problems in animals and/or humans during a pregnancy. So hopefully that this particular patient, she is seeing an OB, they've taken their prenatal vitamin, they do all of this, because if they go to another doctor and they never admit that they had any type of pregnancies or anything like that, they could receive a medication that can affect it. So we have to be careful there. So a category A drug does pose the least at risk of a pregnancy patient. Now, while category X does pose the greatest risk when we break out those different categories. So the 5 category systems is being replaced by a more detailed system. When that comes out, who knows? The 5 categories, let's see, I said that. So there are still many drugs we just don't know what they can do to certain females during pregnancy. So a lot of times your physicians won't prescribe anything besides Tylenol and ibuprofen to pregnant females. Y'all hang on 2 seconds. All right, sorry about that. So now you may be able to quickly evaluate the risk versus the benefits of any type of drug administration. So if you're uncomfortable with giving a medicine to a pregnant female, that's okay, because you're more worried about the risk, the unknown risk, while they're during their pregnancy. If the drug is the only option for saving the woman's life, then that consideration would be paramount. When in doubt, contact med control for guidance. That's why we always have online med control. We can call our med controls. You can call your local receiving facility and be like, hey, I have an important question. I need to give this drug, but she is pregnant. How far along? They'll ask how many weeks, and you're just like, 12, not pulling it out your hiney, but you need to know that information, because when they ask, they may tell you, how far out are you from the facility? I'm 15 minutes. Okay, well, just hold off until you get here. Or if you're 30, 40 minutes away, they may tell you to administer a certain dosage. But if they do, make sure that you document the physician's name and what receiving is. So if you have a generic number that you dial for for a med control doctor, it may be with your agency, or it could be with the facility. So you need to know what facility that this doctor is at, and make sure that you have you don't have to have basically the correct spelling, but the correct doctor's name and repeat back to them. Okay, so you're saying give such and such drug. Is that correct? Yes. At this dose. Yes. Okay, what's your first and last name again? And they know the system. They know that. They know how that works. So they're prepared to answer those questions. So you want to make sure that you get the right drug at the right dose at the right time. Come on. All right. Now, obviously, when we talk about pediatric patients, we know that they're going to have a lot of different effects versus an adult. So we have to be very careful about that. Young infants do have that sharply reduced metabolic capacity. They're not able to break down that medication as well as we are. So incomplete development of the gastrointestinal tract does slow that absorption. Some oral medications, and it delays the elimination of that medicine. Remember, you're using a way smaller dose on that. Remember, we talked about that little small bottle versus the 1 liter bottle. So think about that when you give medicines to your children or to the pediatric patients you deal with. We have to be cautious on giving it because they can't absorb it and they can't break it down as fast as we can. So children can metabolize some medications way much more quickly than adults, but they also may require some relatively higher dosages and then that more frequent dosage. So some of the products of metabolism in children can vary from those seen in adults, which sometimes results in an unexpected response. Now, that is one of those you're like, oh God, I didn't expect this to happen. Well, that's that one particular incident that patient has something different. Now, obviously, correct documentation, being very open to the facility. Hey, I gave this, here's the dose I gave, and this is what I got out of it. A bolus 200 cc's, just tell them what you did. We don't need to hide it because then that makes us look worse. And then they may come to find out that they may have a liver or a particular issue that's what caused that reaction that we see. Now, geriatric patients, we know that the change in the pharmacokinetics in those geriatric patients, they're kind of comparable to our young children. So we're not going to be like, oh, we need to give them, same dosage as a kid. Let me read that. That's a statement I think is really good. Lindsay says, side note, people who have any type of gastric surgery, mainly weight loss surgeries, speaking of someone who has a gastric bypass surgery, can't have NSAIDs and their absorbency is different and they will metabolize different. That is very, very true. So again, we have to ask sometimes those questions when we start diving off into our patient assessment that we ask those right questions because there's some people that just don't give that information out. They may not want that information out there, and it's not like we're kind of post that on Facebook or anything, but we need that information so when we give them particular medicines, we're given the right medicine that's not going to harm them. So that was very good. I'm glad you said that or typed that. Why does it not like to go? All right. So our scope of practice as an advance, we are legally, morally, and ethically held at a very high responsible. We're held very responsible on everything we administer, from a medication to a inhaler to oxygen, because we have a better understanding of what's going on. Now you must have a good foundation knowledge of what is out there on the OTCs. You need to have a good understanding of prescription medicines that are going to interact with the medicines that we give. So knowing the ins and outs and who, what, when, where's, and whys of the medicine that's on your truck will help you drastically have that knowledge when it comes down to giving that medicine and you're like, wait, can I give this NSAID for this particular? Well, remember in class, I heard, Lindsay made a statement. It was very good. She brought that up. Was we can't give those to anybody that has that the weight loss because they can't metabolize that. They can't break it down like we normally can that have not been through that. It is not a problem. We can go around it, but we need to know that information. Let's see. You need to know a good knowledge on obtaining a medical history from a patient from who aren't able to communicate. You may have you're deaf, you're mute, your nonverbal patients. We may have to ask a caregiver. We may have to write things down. And we need to make sure we put those things, if we have to write it for a patient, in a way that they can understand it. We don't want to over talk to them because then it's going to be like, I think they're being mean to me because they're trying to show that they're smarter than me. So again, thinking and knowing that is a good thing because we got to have different ways to communicate. Like, I don't speak Spanish at all, and a lot of our crew members on the rig are Spanish speaking. I have great translators. Well, the translation versus Spanish to English, there's not a word for it sometimes, or it means different things. So when my translator's told some of the things, he has and I've been talking really good, some good information, and I'm sorry, y'all. Thank you for saying that. Whew. What's the last thing y'all heard me say? This is when I check y'all's memory on things that y'all heard me say last. Okay. All right. So I don't know what happened. Sorry, I may have hit the wrong button. So our translators, when they don't know how to translate some things to English, so they have to sit there and think about it. So at the same time as when I ask certain questions, I don't try to be like, are you, I try to break it down and be like, you got high sugar or low sugar? Well, a lot of people understand that. They get that knowledge, and I don't want to be like using the proper terminology and trying to speak super high because I know, and it's like that's not right. It's hard when you do that. And then the usage of symbols. Well, up means up and down means down, but some folks may get that as a different type of. They may be using that as for they need to stand up. So it's hard when you're in the back of the truck and you're trying to write this and you're like, oh, how I write this. I need to do it the right way. But a good flow of communication will help you build that medical history with those patients. So drug administration must be safe and therapeutically effective. You need to make sure you always keep a field guide or other medication reference handy to look up unfamiliar medicines. I'll tell you, quick, fast, and hurry. There's times I've been in the back of the truck taking care of a patient, and I whip out my phone out of my pocket and be like, okay, what's this drug? What's it do? So again, those field guys are very good. At the same time, as we all have phones, we can't. I always like to say we can't function without a phone in our hand. But that's the generation that we're in. My dad could go a week without a phone, but then the next minute he's like, well, how do I do this? What you need to show me what you're doing. Oh my god. Versus my son can carry on well, all of my kids can carry on a conversation with me talking and texting and looking this up, and you're like, bro, are you paying attention? So having that technology is very, very good into the field that we're in. All right, let's see. Why is it? There we go. So methods of drug classifications. All right, so drug classifications are based on the effect of the drug will have it on that particular part of the body or a specific condition. So many medications fall into one or more categories. Drugs or medications can be classified into three categories. So the body system, so categorizing by the system of affected by that particular drug. And then understanding which systems are affected by which drugs is going to help us make those appropriate decisions for our patient care. Now you have the class of the agent. This tells you how a medication affects the system that it's designed for. And then the mechanism of action. It's the particular action by which the drug created its desired effect on an organism. I can tell you there's a lot of times I don't know that. But I mainly know the body system and the class of the agent. I need to know what it's going to affect, and I need to know how it affects that system. I don't know why some of the antibiotics work versus given, like a doxycycline versus given a total different, antibiotic. Like, why are we giving this one? We just gave the other patient this. So I ask those questions to my physician a lot when I'm out offshore and call for assistance. One is I want to get better. I constantly want to get better. Teaching you guys, I want to be able to pass on some information that is up to date versus, like 2020, because that's old information. It is still important, but we need to pass on very good up to date information. So learning, a constant base of learning will help you in this field. It is not, oh, I've already taken registry, I'm done, I'm advanced, here we go. But you still, like, you may get a new drug on your rig. Well, how's this drug affected? Because I'd show you my age here is when we used to use morphine, like handing out candy. Well, when they brought in fentanyl into the world, I was scared of the drug because of what it did, not the drug, not the street version, but of what that drug and the potency of that drug. So time has broke me into it, and there's other medications out there, but I've gotten more comfortable with it versus now I'm like, I don't want to go back to morphine. I like how this drug works and then what it does. So being comfortable with that is going to help you out in a big way. Learning those medicines, moving on and continuing to grow is very beneficial. So the nervous system classification. All right. So nervous systems in the body, principal control system. We know that it's the nervous systems. Also, we're going to talk about our CNS and our peripheral nervous system. So the CNS, or the central nervous system, is made up of the brain and the spinal cord. The peripheral nervous systems includes all of the nervous tissue outside of the CNS. So anything outside of the brain and spinal cord is going to be a peripheral nervous system. So peripheral nervous system contains the autonomic nervous system, or the ANS. This controls all automatic involuntary functions. Like, it blows my mind that we think as grown adults, and I still think I'm grown, but I don't feel like I'm grown, is that my body breathes and functions without me having to tell it. That is amazing. Like, that blows me. I know how it works. I know that is a involuntary function. But if I had to think about breathing, blinking, talking, swallowing, taking a deep breath, I don't know if I could do it all. I don't. It's just, I can walk and talk and chew gum, but if you think about it, if people had that we know that had to do all this, we may have less people in the world because they may not be able to do that all. So the ANS is divided into your sympathetic nervous system and your parasympathetic nervous system. So the sympathetic nervous system is responsible for the body's response to shock and stress. It is also known as your fight or flight division. This response is associated with the release of adrenaline from the adrenal glands. Again, that's where your fight or flight comes from. Your adrenic response, because of special adrenic nervous fibers, ultimately cause the release of those hormones or epinephrine, also adrenaline, or norepinephrine. It automatically does that. The sympathetic response includes shunting of blood from the extremities to the vital core organs, dilution of the pupils, and the reduction of the digestive system. So in a time of shock, our body's going to take the blood from our toes, our legs, our hands, and it's going to bring it to the core, to where the main core functions still take place. Now, granted, we're going to still have the ability of our toes moving and all that back in time, but it's going to take a lot of that blood from it. So our body's not having, we're going to have that automatic compensation. So our body's going to automatically compensate because of a massive blood loss or a traumatic, event to a particular area. So again, that just blows my mind that it can automatically do that. That is awesome. The parasympathetic nervous systems help relaxes the body. It does control the automatic functions during non-stressful times. It's also referred to as the rest and relax division. Stimulation results in the effects opposite of the sympathetic nervous system. So an example, so heart and respiratory rate decrease, constricting the pupils, and it does increase the digestive system activity. That was a lot. So the sympathetic and parasympathetic divisions work constant opposition to maintain the harmonic activity of within the body. So it's going to continue to, one's going to go up, one's going to decrease. It's constantly changing to help us function. So each division takes more precedence and their proper circumstance. So when one needs to kick in and get going, the other one backs off. When the other one's kicking in, the other one starts to back off. So they constantly change. So it is not a 50-50. One day 70-30, the next day, 60-40. It's great that our bodies can do that without any really a lot of thoughts to it. Hormones released by the sympathetic system, stimulation, are carried throughout the body where they cause their intended effects by acting on the hormone receptors. Stimulate tissues that are not innervated by sympathetic nerves, some prolonged effects of direct sympathetic stimulation. And then our adrenic receptors are located throughout our body, and once stimulated by the appropriate hormone, they can cause a response on a particular targeted organ. So we divide those into 4 types. You have your alpha 1, alpha 2, beta 1, beta 2. You will start to see a lot of that kick in when we start talking about cardiology, about your alphas and your betas, not as in radiation particles, but on when it starts talking about the heart. So that will help you understand more of, like your beta 1 drugs or your beta 2s on, because it does particularly for your cardiac system. All right, so drugs that affect our sympathetic nervous system. So our sympathomedics drugs that produce the same effects on a body system as the hormones of a sympathetic nervous system. So we have this medicine that just here's one thing about this. So your TRT or your hormone replacements, it's because your body's pituitary gland is not producing enough. So we have this substance that's made that we can inject or have a pellet put in us that will help boost that up. So we have those, that's a drug that helps us in those areas. Your sympatholitics medication that inhibits the sympathetic nervous system, also known as anti-adrenics. Your anti-adrenics antagonize or fight against the effects of a sympathetic nervous system. That's a lot. That's a lot of pronunciation for me. All right, so antagonist is a drug that counteracts the action of something else. An agonist is a drug that binds to receptor and causes a response. When I read those two, what is one of the drugs that kind of pops in your mind as either one of them? Narcan, okay? That's a really good one. What about if I'm having an allergic reaction, what drug are we going to give? Epi. Okay. So our body produces that already, but we don't have enough, right? So now we're having to Benadryl. Both of those are correct. Epi and Benadryl. We have those because those are going to counteract a particular action that's taking place within our body. Zofran, man, that's a great drug. That's one of the best, in my opinion, one of the best ones out there. My son goes Xanax. So I have other questions with that comment. So we have those medicines. So remember, those medicines are made as an antagonist and an agonist. So we have those that bonds to those receptors. So that's in your toolbox. Know what those drugs do. Know what they have other actions to be done. So this right here is going to help some of y'all. All right, some medications that stimulate some alpha and beta receptors, where others are selective to a specific receptor. So beta blockers are used to control blood pressure in some patients and then heart rhythm disturbances in others. So I take a blood pressure medicine. Thank God, it's amazing. So I don't need it for my heart, but I need it to control my blood pressure. So this is worked by filling a portion of the beta receptor sites that beta stimulators would normally bind. In our pre-hospital setting, you will often administer a drug that agonizes the beta 1 receptors in an attempt to create a cardiac arrest or hypotensive. So we know what those drugs are. So we want to make sure, again, those are going to be given by IV. So when I said earlier, don't give a medication unless you got an IV, and there's the reason why. Beta blocker propanol is used for cardiac tachycardia, and I can't read the rest of it. Let me pull it up. And for anxiety PTSD. So those are great, great drugs. So they treat two total different things on a certain therapeutic range. So we have these medicines that are out there. No, we can't carry them as advanced, but some select medics can have that into their particular toolbox. You have like your critical cares, your flight medics, your flight nurses. They have those drugs that in certain times they're going to use for certain reasons. It's different drugs can be used in a therapeutic range for certain other symptoms. All right, so parasympathetics is an antagonist to the parasympathetic nervous system. This is also called cholinergic medications because they stimulate the cholinergic receptors to which ACH normally binds. Cholinergic medications may act directly or indirectly on those cholinergic receptors. Anticholinergic drugs acts to prevent activation of the receptor by binding to those. So when a drug interacts with a ACHE, it deactivation of the ACH does not occur. So it is not going to just, whoop, that drug's done. We're not going to use it more. So it does that. It's not going to stop those there. So if excessive cholinergics are present, the patient may exhibit a sludgem. Y'all remember those when we talk about our exposure to certain chemicals. And remember sludgem, for the ones that may not have the fireside into them, you have your salivation and sweating, your lacrimation, urination, defecation, and or drooling and diarrhea. You have your gastrointestinal upsets and cramps. You have your vomit or emesis, and then muscle twitching or miosis. So patients that were exposed to a certain type of fertilizer, your insecticides, your VX or nerve agents, and the sarin gas, they do exhibit those sludging symptoms. Again, a long time ago, I went to a school where we got to play with VX. So nervous as all get out, and we were exposed to we had serum gas in the room. We were all in gas masks, but seeing how they affected the mice that were in the room helped us understand in the medical side, you got to act and act fast because you're already behind the 8 ball. When you start seeing sludgeon symptoms, you got to be moving. So having the understanding of those when you go to a particular incident, it's a mass casualty incident, or you start to see these signs and recognize them, you can say, oh goodness, there may be a nerve agent. There may be a particular chemical compound that's causing this. So you have to step back and then you have to protect yourself. So knowing sludgeon symptoms, what it all means is going to be very important the more we go into our fields and the more things, and knowing what's in your particular environment. If you work in a area that has these fertilizer factories or the insecticides where they're made, they're going to have these antidotes on site for their crew members. Now that's a whole different type of going down that lane, but knowing what's in your response area is going to be very important, and knowing what to potentially have on your truck, because we're not going to have enough atropine if you go to a mass casualty incident and you start seeing these sludgeon symptoms. So know that already. All right, so antagonist to the parasympathetic nervous system. Atropine is one of the most commonly used for a parasympathetic event, also called anticholinergics medications, because they block 2 types of receptors. You have your narcotic and muscarinic. I may not be pronouncing that right. Here, muscarinic cholinergic antagonist blocks the ACH exclusively at the receptor site. Prime example again is atropine. Having enough atropine just for one person, I know by what's required by the state of Mississippi, there is not enough of atropine on one ambulance to treat one patient completely to get them from the site to a facility. So you may work in one of your areas that has like 30 atropines on the truck, and you're like, my God, why we got so much? Well, that there may be a reason what's in a particular area versus not in another part of your area. So I would start to ask those questions, in my opinion. All right, so analgesics and antagonists. Analgesic medications that relieve pain to include analgesia, or the absence of a sensation to pain. You have your opioid antagonist. Most common class of medications used for analgesics is in the pre-hospital setting. It is similar to or diverted from the opium plant. This does bind to opiate receptors, which prevent those particular neurons from sending any type of pain signals. It is a CNS depressant. Fentanyl is one of the most popular agonists because of its rapid acting. It is very violent and has a relatively short duration of action. So when I give somebody offshore 50 mics, I'm not going to get the same reaction to a person that's 300 pounds versus 180 pounds. It's going to be a short-lived medication, but it's going to react different to different ones. So instead of giving 50 for the 300-pound guy, I may give it for 100 mics. Versus if I gave 100 mics to a 150-pound person, I'm going to snow them under. So you got to know your range, and you need to know what your protocols are. Because of it being such a short active drug, giving that medicine in the right time, you can, provide some high flow O2, give them a bolus of fluid. There's some things that you can do if you draw up all of your medication instead of 50 and 50, and you accidentally give 60 or 70 because you may hit a bump or you'll have to slam on the brakes or something. Knowing that's why you should only draw up that particular desired dosage instead of the entire amount. I'm real big into one of these like Don't use needles when you're moving up and down the road. If you have to, make sure you lay it down in a working area so you don't poke yourself or you draw the exact amount, because if you do hit a bump, it's not going to be that big of a deal if you give it in a fast IV push or a slow push. But if you fastly push 100 mics and you're only supposed to get 50, you're like, oh God, uh-oh. Yes, you're going to have to write a report. You're going to do some other things, but justifiably, it's easier to draw what you need. Just saying. You won't get as many questions. So no non-opioid agonist. Many are available as an OTC drug. Many have an antipyretic properties, as well as meaning they can reduce a patient's fever. All of them alter the production of prostaglandins and coxagens or COX to produce their effects. Man, I wish there's a lot of these. I need to change some of these slides so y'all can see these words are killing me. So 3 forms of the particular property. You have your aspirin. Aspirin does target your COX-1 enzymes to reduce that platelet generation. It does provide a great benefit into patients who are suspected of having a myocardial infarction. So we want to give that 81 milligram tablet to 325. We need to make sure we have that particular right medicine and we give it at the right time. Can I take that aspirin if I've got a really bad headache on the truck? Yes, you're going to take a lot to get to the therapeutic range for your headache, but you got to make sure you get the right one for that particular situation. Your non-steroidal anti-inflammatory drugs, again, your NSAIDs. We talk about your ibuprofen. We know ibuprofen does help with the pain, inflammation, and fever. But the reason why is it works by inhibiting the COX enzymes, and that will produce the chemical that promotes pain, inflammation, and fever. So we're trying to bond that particular drug of the ibuprofen to lower that. So if we block it, it can't go up. It's got to go down. So that's why that medicine works the best. And then you have your para-amphiterol derivatives. We talk about that instead of as in Tylenol. That's one of the biggest ones right here. Acetaminophen is in your Tylenol. Opioid antagonists. Now, we know we've talked about Narcan. Everybody's, unfortunately, you can buy that over the counter. I still have issues with that. That's one of those big things. I'm like, we're enabling the wrong thing. Personal opinion. We know what it does. We know it reverses the opioid drugs. And it does that by binding with that particular opiate receptors in an antagonist manner. As the result of that binding, that particular opioid molecule cannot get to the receptor, and that receptor cannot initiate its particular action. So Narcan is obviously our most common in our pre-hospital setting. It's the easiest to use. It's the easiest to give. And Rob and I have talked about this before. I actually have a program about Narcan. It's approved by the state of Mississippi. You can give it, and you can actually get CEUs for it. But the dosage of Narcan that we carry, and we can give it in a slow push versus what they sell in the store and versus what the state of Mississippi supplies to our police officers, is a different dose. That's the reason why if your police officers get there and they deliver it, they're delivering a double dose of it versus what we are in singular dosages. So when your patient starts to fight and they start to have all this, and then they look at you like, hey, it's your turn. You got to get them. Cuz I didn't do it. You did it. You get to fight with them. So understanding all of that helps you educate your officers and the public on administration. It's hard for them on those little one-time inhalers to give a slow push of Narcan. It doesn't work that way. So you need to know what your effects are going to be. I can tell you, I'll tell you a bad story. There's times you've been to a facility time and time and time again, and they give you hell every time you go because you didn't get this done, you didn't get that. Why can't you do this? And then you roll in with this, overdose, and you've been titrating to effect on your Narcan to slowly bring them around, and you give that last quick bolus push as you walk into the ER and be like, well, he's your patient. He's fighting. I don't know what's wrong. That is not appropriate. It's not the right thing to do. Not saying that it's not done, but Narcan is great in titration to effect. If you want to get in fights all the time, then you're gonna slam that Narcan. You're gonna constantly get your patient and those adverse reactions. Be cautious, even when you itemize it and you put the nasal inhaler on there give it a half dose, half of the half dose in one nostril and the other in the other nostril. It helps it work better. And also, I like pushing it and then bagging that particular patient because I'm helping it get into their system so it can bond with those receptor sites. That's a me thing. I've learned over time not to always slam it. Just saying it's a bad thing. All right. So anxiety, sedation, and hypotonic drugs. Drugs are used to help a patient sleep through a medical procedure by producing some sedation or some hypnosis. Drugs that create sedation and hypnosis include benzodiazepines, some sedatives most commonly used to prepare a patient for an invasive procedure. Man, that's some of the best sleep in the world. Excuse me a second. Sorry, I almost had to danger one of my dogs. All right, so back to this. So, and your benzodiazepines, it is believed to affect the neurotransmitters. We talk about your GABA, your gamma aminobutyric acid, in the brain. Your barbiturates are believed to work very similar to those benzodiazepines by increasing the affinity between receptor sites and the neurotransmitter of your GABA. So your non-barbiturate hypnotics, they're identical properties to those benzodiazepines and barbiturates and how they affect the particular GABA receptors. However, they do tend to have some comparatively few side effects. We talk about the side effects, particularly into your cardiovascular system. So that's sometimes why you get those barbiturate hypnotics versus the barbiturates or the benzodiazepines, because you may not be able, as in your body may not be able to absorb that as well for your cardiovascular system. We don't want to compromise that, so that's why they give those non-barbiturate ones. Your anticonvulsants, we know we give those for our seizure patients. Great drug. So your active seizures generally require treatment in our pre-hospital settings. We don't just want our patients to continuously seize and, we're like, well, that first one was 3. Let's see if we get to 5. That is wrong. We're causing harm to our patients, so we need to stop them. So your anticonvulsant medications, it's exactly mechanically, but bind that does not, we don't know why, but that does it, they do their job. That medicine was done to stop it. We believe that it's done by inhibiting the influx of the sodium to the cells, but we really haven't dove so far off into that study where that medicine's released. We know what the anticonvulsant medications do, what they're made up of. We know, but you can kind of, we don't have that information out there and just say this is the particular reason. So it does decrease the cell's ability to depolarize and propagate those particular seizures. You have several other types of drugs that are used during your anticonvulsants. We have your benzodiazepines, your barbiturates, your hyaluronidates, and then your valproic acids. Excuse me, I gotta get something to drink. All right, so our stimulants. We know that our stimulants help with our CNS agents. They exert their action. Versed, yes. Let me read that statement. Versed is a good seizure in the field and sedate out of control patients like psych patients. I know in our local protocols, versus what I use offshore, Versed is a very good one. It is very good to also help sedate that seizure patient, but make sure when you get ready to use the Versed is you may have to produce that advanced airway. Yeah, you may have to bag this particular patient because it may have that reaction to where, oh, now I got to start bagging this patient because they're now having their respiratory system. It's not compromised. It's just delayed a little bit. So we need to be prepared to bag those patients. Stimulants. The stimulation of the CNS, we accomplish that by increasing their excitatory neurotransmitters, and we decrease the inhibitory of those neurotransmitters. Certain stimulants will affect either side. So some of the stimulants that we have examples of, we talk about caffeine, cocaine. Whew, that's way all in the different spectrums there. And then we have your prescription and illicit amphetamines. Now, increase the release of dopamine and norepinephrine to increase the wakefulness and awareness of a drowsiness and a fatigue. So we talk about like I just literally went blank at what I was supposed to say, so I'm gonna continue reading. That doesn't normally happen a lot, but so some high dosages can cause some increased nervousness. You have your irritability, maybe some tremors or headaches. Those right there, those are side effects. Yes, I do. I should have taken my medicine before class started, but I didn't take it now. I don't take offense. I think it's funny. It's great because you are correct. Now, some people experience withdrawal symptoms when they stop taking those stimulants instead of winging themselves off. So, a lot of your physicians will lower a dose of a certain medicine and give something to counteract that as they lower you. So, you're not having those withdrawal effects because, again, some of those withdrawals can have those tremors. You can have those headaches because you're like if you're coming off of caffeine. I've known some people they're like, all right, I'm stopping today. Wait. Like you need to you need to dive off in that. I went a long time without drinking any type of caffeine, but I started having a lot more headaches and I knew that the caffeine would help with that. And I broke that trend. I wish that I would still limit my intake, but you get that. You get those withdrawals when you just automatically stop. So slowing those down is done a lot with your physicians to get that patient off of that medicine or onto another one. All right, so your depressants, your CNS agents that slow the brain activity. They may be prescribed to treat some anxiety, muscle tension, pain, insomnia, stress, panic attacks, and seizures. Some of your CNS depressants are used as a let's see, like here's some example of some of the CNS depressants. So we talk about our Ativan, your Valium, your Xanax, and Ambien. Ambien works great. It helps people stay asleep, gets them to sleep. Now you may have that adverse side of the Ambien of I call it the Ambien text because some people that take that they don't recall. They send out all these text messages or they do things in their sleep when they, let's say, with their partner or things that happen that they just don't remember, and they wake up and like, what? Why am I here? What am I? Oh God, what did I do? So you have to be cautious of that. Of all those medicines, some of the things like Ativan and its normal use is great. Valium is great. All of these, but they do have the ability to have the overusage or the side effects of being overused or underused that can cause some major issues. Your psychotherapeutic drugs, they work by blocking your dopamine receptors to the brain. They are used to treat those illnesses like schizophrenia and depression. They are associated with a host of side effects, and we do mean a lot. Um, like involuntary movements, those tremors, the rigidity. We talk about muscle contractions, that constant restlessness, the shaking of the leg, the getting up, moving around, sitting down. You can see some changes in their breathing and their heart rate that can affect them into a medical situation, or it can be pretty severe. Um, orthostatic, orthostatic hypotension is treatable, um, but it is a side effect of these psychotherapeutic drugs. Um, in some of them, you will have some sexual dysfunctions. Depression is often treated with your SSRIs or your selective serotonin reuptake inhibitors. So when you go and talk to a physician or a therapist, whatever, and they talk about putting you on these SSRIs, you're like, wait, and you just sit there and nod your head, like, yeah, yeah, I don't know what you're talking about. So we are learning that these psychotherapeutic drugs are out there, but we just need to be careful when you see them. They're going to give you a host of the potential side effects. If you see any of this, call me or call us back. Da, da, da. It's a lot. Uh, yes. So they have been a lot in the news here lately. Um, Honestly, I don't watch a lot of TV. But I know that there has been some talk about limiting the SSRIs in certain age groups, or unless they have certain disabilities. I think that's the easiest way to put it. I don't like generically classifying certain things, but um, they I know that there are a lot of your teenagers in your teenage range are trying to give something else than your heavy SSRIs. I do know that it can cause some issues. So your SSRIs and your MAOIs, which is your MAOIs are your monoamine oxidase inhibitors. Your SSRIs and your MAOIs, they do block that metabolism of your monoamine in the brain. Your TCAs, your tricyclic antidepressants, those are occasionally used, but we're not really like, we've moved on to your SSRIs, more common than your TCAs as time goes on. Those are kind of your older treatments. They still work, and they may work in like a mental institution to where they can, but be very regulated. But you see a lot more of your SSRIs or your MAOIs in their classifications. That is a very wide range of those three there's a lot of different medications in there. So it's one of those, if you see it, you Google it real fast and you're like, oh, I know what that is. So now you understand you have the abilities for your SSRIs and your background and your knowledge. Come on. It just doesn't like to go. So drugs that affect our cardiovascular system. So we know the walls of the heart are compromised a lot of interconnected cells. They do specialize to serve some particular functions. So those medications target the cardiovascular system. Those are classified according to their side effects on those particular uh, specialized cells. Now, the effects on the heart are categorized as the following. You have your chronotropic, which affects the heart rate. Your inotropic is a change the force of contraction. Dromotropic, they do alter the velocity and the conduction of electricity through the heart. So it does two things. All three effects can be positive or negative depending on the dosage. Some cardiac Glycidoses, class of medications derived from plants. They do block certain ionic pumps in the heart cells, which directly increases the calcium contraction, sorry. And now those particular ones have a large, very large side effects. There's a vast side effects that those cause. I do know one person that's on the glycidides that those, but it's very like he's had a lot of heart issues over time. They control what he has, but he's like, dude, like you have to make sure that medicine's kept by itself and you have to take it exactly what it says. So being cautious of that is one of the bigger things. Your why am I having so much trouble? Rhythmic medications. So we know what it's going to do. We know it's going to change the rhythm. So this has been long used in the pre-hospital setting. It is to prevent some particular cardiac rhythmic disorders. So it can have a direct or an indirect on some cardiac tissues. It is classified into a group according to their fundamental node of action of the heart, like your sodium channel blockers. That has a slow conduction through the heart. It negatively affects the dromotropic side. Your beta blockers, they reduce adrenal stimulation of those beta receptors. Your potassium channel blockers increase the heart's contractibility, which is positively through the inotrophy side. Your calcium channel blockers decrease the force of contraction and automaticity. The decrease of conduction velocity, which is a negative dromotropic side effect. You'll see a lot of your beta blockers and your calcium channel blockers. Those are kind of your bigger ones that you see out there. You start to see some sodium channel blockers and your potassium. You know that they have a pretty extensive heart condition. And they're normally on a lot of medicines when you start getting to that point. Your antihypertensive medications, they do treat your hypertension. We know that their particular goal is to keep the blood pressure within normal limits. And depending upon what kind of physician or nurse practitioner you see, their ranges are going to be different. I had one time tell me that, hey, your blood pressure is high, but I'm okay with it. You know, that's the normal range for what your job does. But then my nurse practitioner, she's treated it and got it to a better therapeutic area, and I feel so much better. The diuretic medications, we know that this does cause our kidneys to remove an excessive amount of salt and water within our bodies. It does reduce the stress placed on our cardiovascular system by lowering the total amount of fluid that's within our body. So the lower the preload on the heart and the decrease the stroke volume, amazing. That is wonderful. Your vasodilator medications, they do act on the particular smooth muscles within our arterioles and our veins. This explains why your nitroglycerin is so beneficial in treating your myocardial ischemia. So now you know why when you give nitroglycerin, what it's doing. It's affecting those smooth muscles. Now, however, some dilation of these vessels promotes a response from your sympathetic nervous system. So when your vasodilators are used to lower your blood pressure, the patient must also take medications to inhibit the sympathetic nervous system. So remember how we said it's 70-30 and then they go 60-40? You've got to counteract the other side. So that's why those medications are used. So sympathetic blocking agents, these do include our beta blockers and our adrenic inhibitors. Your beta blockers do compete with your epinephrine. The reason why is because it bonds in some available receptor sites. It does diminish the effects of those beta stimulation, but we need those beta blockers. If you're in a position to where you're having to take that, that's something your cardiologist is going to work on. Your angiotensin converting enzymes or your ACE inhibitors, they target the renin Oh, you talk about needing medicine. Literally, I was just going right along and something else came on my mind, shut me down. So the suppressor, the conversion of the antox 1 and the antogen 2. The second one it potents the vasoconstrictor that promotes the smooth muscle contraction in the arterioles throughout the body. Now, the constriction does raise the blood pressure by increasing the peripheral resistance. So your calcium channel blockers also have those anti-dysrhythmic and the anti-hypertensive properties. So your calcium channel blockers are going to help do two things. We're trying to keep the dysrhythmia changing, but we're also trying to work on their hypertension. So you may be you will see some patients taking those hypertension medications along with calcium channel blockers and wonder why they feel like trash. Well, it's because your blood pressure is so low, you're you're not getting enough blood. So again, knowing your medications, you're a very big proponent to your patient. You're able to provide them with information as a hey, I love to say this, so I'm just a dumb old paramedic. So us dumb old AMTs are teaching our patients to go back and talk to their physicians about, hey, I'm on both of these. Oh, well, why are you on both? Well, you put me on calcium channel blocker, well, my regular physician put me on hypertension med. Now somebody has to stop doing something. Which one? And most of the time, your regular physician will take you off of that because your cardiologist wants you on those calcium channel blockers to help with the cardiac side. Anticoagulants, fibrinolytics, and blood components. So these are platelets that they help repair the damage within the blood vessels. It affects in the blood vessels, can cause blood flow to slow. We know that they start building up with a lot of junk in their system. If the blood flow starts to slow significantly enough, we may have a blood clot or a thrombus starts to form in that particular area. So an abnormal thrombi may cause a life-threatening crisis such as a stroke. So that's why they're on those anticoagulants. Now remember, if they're on those and they have a small cut or a skin tear, they're going to bleed profusely. A variety of medications are used to prevent or minimize the detrimental effects of a thrombi, like your antiplatelet agents. They do interfere with the collection of platelets in the area, but they do not break. They do not break down aggregated platelets. It helps prevent further buildup within these blood vessels or blood cells because they're like giving. I know this is bad terminology, but it's like taking Drano and pouring down your sink or your toilet. But that's what these medicines do. It's helping clear out the pipes within our body. Your salicylic acid has a significant antiplatelet properties. This is very, very important in our pre-hospital setting. Your anticoagulant drugs works against coagulating to prevent the formation of that thrombi, so we can keep them from stroking out on us. But you need to be aware on these anticoagulant uses, particularly in a cut or in a traumatic situation. If they've received any type of traumatic injury, and you hear them saying they're on a clot blocker or their doctor gave them something to keep them, why are you bleeding so much? You're bleeding like you've cut an artery. Well, I'm on a blood thinner. Wait, what'd you say? So again, that might be what requires that bolus of diesel because of what they're on. Some fibrinolytic agents, they may be administered to dissolve those thrombus to prevent it from breaking off and entering into your regular bloodstream. This promotes the digestion of fibrin, the protein involved in forming a blood clot itself. Use in the pre-hospital setting remains very controversial. I know there are some studies going on in some of your larger cities that have closer ambulances, closer hospitals. Some of your units are starting to carry blood now on ground instead of air. And that big study is out there on if a provider recognizes that there is a stroke or a particular clot due to some field signs that they are administering these fibrinolytic agents in the field under some scrutiny and very close watching of physicians. So it's not like, okay, I'm going to push this. There's studies out there to see if it is a very good thing for providers to carry, or they're going to limit it in certain fields. Currently, that I know of, no service in the state of Mississippi carries blood on them besides your air medical divisions. I know Texas has some services out that carry blood on their truck, and it is a specialized unit or either a sprint truck medic has those particular. It's kind of like RSI, and it's coming more and more relatively available and training out there, but this carrying the blood has not made it to all your units yet because all the stuff you have to give blood that's a lot of equipment, like as in keeping the blood, moving and keep it from clotting itself. New Orleans EMS has blood on their sprint units. Let's see. I did know New Orleans did. So New Orleans, I actually taught a recent class that one of our federal agents is part of New Orleans EMS, so he can do certain things when he's on the federal side, and then when he's on the advanced side, he can't do. But he does a lot of work with New Orleans, and I knew that they had it. And when they have big events happening in New Orleans, they actually have some of those supervisors that carry those drugs go with them, and they obviously stand back. But if it's needed, they have it. So I was aware about New Orleans, and that's probably one of the closest ones that I am personally aware of. All right, so drugs affecting the pancreas. You have a variety of hypoglycemic medications that are available. Some others may not act on their pancreas directly, but they may alter in the way the insulin is used within our bodies. In the absence of pancreatic function, um, no problem. That's good. Be careful. You can catch up on the last little bit. In the absence of pancreatic functions, patients may take some insulin injections, which we're used to that. Insulin sensitivity is increased by oral hypoglycemic agents. So it depends on which particular ones that they take. There's some changes out there that's being made. So drugs that affect our immunologic system, immunosuppressants medications are often prescribed by patients who have undergone some type of organ transplant or they had that autoimmune disease. Immunosuppressants are intended to inhibit the body's ability to attack a foreign organ. So we're stopping our bodies from doing our natural thing. Wow. From the natural thing because of the organ. We want the body to accept it, not to kill it off because like, whoa, there's something foreign in us. We got to stop it. Now, again, on the autoimmune system, it keeps the body from attacking itself. So, sorry, you have certain conditions that are within our own body that some people can't function with, but they have to take a medicine that keeps their body from killing them. It's crazy, but we know that some of these immunologics drugs are diverged from a fungi or bacteria. They tend to have a complicated mechanism of action, very much so, but it does help inhibit the lymphocytes and the T cells from carrying out their immune function. So we're basically stopping the lymphocytes and the T cells from doing their normal job. But we have to because of things that are within our own body that we may have those immune disease or a particular organ transplant. A lot of times they will take this medication for a while until the body has finally accepted that this organ, hey, we're going to use this. This is going to start going forward. We're going to go from there. Vitamins and minerals. I take mine. I take my mag sulfate a lot for my migraines, vasodilators. But we know vitamins and minerals, they are necessary substances that we need. We need them for our metabolism, some growth and development, and then down to our cellular function. Patients may be taking these vitamins and mineral supplements. They, because of their replacing some deficiencies that they have, or as a preventive measure. Like I take a D3. Well, D3 helps keep um, me from being sick. I'm not saying like I need it, but being on the rig, it is like a it's a functioning virus out there. I mean, you get people from all over, and then they start breathing the same air, and everybody gets sick. One person gets sick. I mean, it's like a bicycle. Everybody's trying to ride it. So I take it to try to keep me healthy. Um, Thiamine is important in pre-hospital settings because it aids in converting carbohydrates into energy. And then again, it is used with people with alcoholism and among some others that tend to be deficient in this vitamin. So thiamine is very, very good. It helps when you have somebody that's going through withdrawals, like alcohol withdrawals. You can give that to them. There's like we have standing orders, all that. We carry thiamine offshore. I've seen we carry it here on the trucks, on the streets. It's good and it works like it's supposed to, but and you're thinking like, oh man, it's one of those drugs that's in your toolbox that you don't use all the time. So when you actually get to use it, you're like, oh my God, look how awesome this drug works. Well, it's been around forever and it's shown and proven and it's great. So thiamine is really, really good in the pre-hospital setting. We talked about this the other day. So fluids, you have your crystalloid solutions. We know that's what we carry in the pre-hospital setting. We talked about isotonic, hypertonic, and a hypotonic. So your isotonic provides a stable medium for administering our medications. It does provide an effective fluid and electrolyte supplement. Your hypertonic helps provide some nutrition, and then your hypotonic is a beneficiary from dehydration situations, not in your hypovolemic cases. So understand that we want to give your hypotonic in dehydration situations. You may also monitor colloid situations to some of your patients, depending upon your areas. But most of the time, you're going to be carrying your isotonic and hypertonic solutions in the field. Drug forms. So the form that a medication comes in usually dictates the route of administration, which when y'all start seeing these slides, y'all understand that part. So your manufacturer of this drug chooses the form to ensure that the proper route of the medication, the timing of its release into the bloodstream, and the effects on the target organs or our body systems. All right, I like this part. This has helped me out a lot. So your solid drugs. So most medications are given by mouth to adult patients are in tablets or capsules. So capsules are gelatin shell filled with a powder or liquid medication on the inside. Except if a capsule contains liquid, the shell is sealed and is very soft. If the capsule contains a powder, the shell can usually be pulled apart. Trust me, like when I went through this in med school, I was like, oh, I start pulling these apart. They look like, yeah, they work, but they're not what like you're supposed to. So tablets. So tablets are often contain other minerals that are mixed with that medication and compressed under a lot of high pressure. So to form pills takes pressure. Some are designed to dissolve very quickly and a very small amount of liquid within your stomach. They can be taken sublingually or absorbed. If it's given sublingually, it's going to be absorbed very rapid. Um, Sublingual or SL, when you go to write, you can use SL for sublingual. Nitroglycerin is one of those. It is especially useful in the field. We know that we want to give that sublingual. Let's see. Generally, medication that must be swallowed is less useful in an emergency situation because of the timing that it takes to absorb that medication. So pills, solid drug that are shaped into a ball or oval can be swallowed. They're sometimes coated to disguise an unpleasant taste. Now, suppositories. Now, those are administered by inserting those into the rectum. They are more rapidly absorbed than medications that must travel through the upper portions of the digestive tract. Now, you will not give any type of suppository medication as an advanced. I've done it once in my career, and then when the doc told me, I was like, "Wait, what did you just say? Wait, you won't what? Hold on, I need you to draw this in a picture for me, doc. I'm not understanding what you're saying." I was in a very specialized situation that I was in, so it did work very, very fast, but I did not want to do it ever again. So liquid drugs. Um, yeah, he gave me orders over the phone for this particular, and I was like, "Nah, I'm gonna put you on speakerphone because I need everybody to hear this." So liquid drugs. So in your picture here, you see all these different types of liquids. Besides the peel formed nitroglycerin in the right side. Okay. So liquid mixture is one or more substances that cannot to be separated by filtering or allowing the mixture to stand. So this can be given by any route. When it's given by mouth, it can be absorbed by the stomach fairly quick because this medication is already dissolved. We don't have to worry about that. Some solutions that irritate the stomach can be applied topical to the skin. And right here in your picture, so this is a nitro paste. This is a measuring tool. We use this. I've used this a lot in the field offshore. But this is a paste, and I think this tube, I can't see the other side, but this tube is your nitro paste. Most time it's a very small packet that comes with, not the tube itself. And you can spread it on the chest. Same thing. It works great. Um, Many of those solutions that you see, or we can give them by IVs. You sometimes can give them IM or subcutaneous. Most of them are going to be given by IV. If you have to give a patient that is that's taken a sublingual, you may have to help them get it in the right place. So make sure, like I tell everybody, look up at the lights. I want you to take your tongue and stick it to the top of your mouth. Don't close your mouth until I tell you to. I used to take the nitroglycerin in the top and pour it in there, like with wearing gloves, but it's so much easier just to take it with your fingertips and put it in there underneath your tongue. I know I don't like putting my hand in somebody's mouth, but I'm not going to do it to somebody that's seizing, obviously. Um, let's see. In suspicion, most substances do not dissolve well in liquids. Some can be ground into fine particles and evenly distributed throughout a liquid by shaking them stirringly. There's one medication particularly that I can think of that we mix with a mixing solution. Activated charcoal is used in patients who have overdosed or ingested certain poisons. Let me tell you a secret about activated charcoal. If you're squeezing that in somebody's mouth, they sneeze, they cough, or they vomit, you're going to have fine particles all over your truck. So if you have to clean your truck when you get ready to turn it in, or if you're getting to the hospital and you got this stuff everywhere, you're going to have to clean every particular spot because it goes everywhere. Just saying from experience. Let's see. Now, very rarely you're going to encounter some type of liquids that include some alcohol in their preparation. That's a mixing. That's very rare that I can think of. And you may have that on a specialty truck or even like a nurse truck. I having trouble thinking of one right off the top of my head. Tinctures is the name of a mineral contained in the tincture. Other than alcohol is added to the name of the particular one. Obviously, spirits is an alcohol solution that we don't carry those. Sometimes I wish we did. Just take a shot here and there, we'd be good to go. Some elixirs, one of the most common type of medication preparations that are taken orally as a liquid. We probably take a lot of those at home for like coughs, syrup, some oral medications. They taste really bad as adults. They don't give us the bubblegum flavor anymore like they give the kids. You have your syrups. Your syrups will contain a lot of sugar. Yes, so glucagon is one that you got to mix up. That's true. Very good one. Most commonly used for children's medication is your syrup, your emulsions. It's a mixture of two liquids that are not normally mutually soluble. Have fun with those. Generally, a mixture of water and oil that must be thoroughly shaken, and not just like, oh, I'm gonna shake it a minute or two. No, you got to shake the mess out of that. It's because it doesn't want to bind. It's not supposed to bind. So meter dose inhalers, we've all seen these. We've used these either ourselves or on some of our patients, also called MDIs. On your MDIs, they do deliver the same amount of medication each time it is used. So before giving these, make sure that you shake them very vigorously. That way that the medication is not, yeah, they're under pressure, but understand that you don't have it sitting on its side for a while and it's kind of laid there and you're like, well, it says you've had it for 90 days and today's day 30. There's a lot of there's a lot of dust on this. Is this the wrong one? So make sure you shake them up real well. Um, Again, as y'all see on the bottom, it's most of your patients with any type of respiratory illness have these on them, like your asthma patients or your emphysema ones. They're gonna have those, and with gonna be within reachable. They've used them a lot. They probably could teach you more about those than anything else. Topical medications, we talked about the nitroglycerin. You have your lotions, creams, and ointments. Be very careful with some of these because if a patient has a topical medication on them, like if, let's say I had my patient that had the nitro paste on there and you went to assist the patient, get him off the bed, and your arm touched their chest by any reason, you will get some of that medication on you. So be very cautious. Um, Look for some transcutaneous medication like the patches. Some folks have those fentanyl patches. Um, you can have your nicotine patches. Make sure that any time that you see these patches on there and you're working a cardiac arrest situation, remove them. Um, there has been a study, and it's an old one, but a patient was shocked, and due to the body's reaction and all that, they absorbed too much of it. Um, but it is also a very good user-friendly thing. If you see patches on there, ask them what those transcutaneous medical patches are used for. Just so one, it's your knowledge, and a lot of them look like those band-aids. It could be nicotine. I mean, like a Nicorette patch or something like that. So, but just it's a general knowledge to check their arms, chest for those particular patches. Gels, here's your glucose. You have your glucose tablets. Remember, please, please, please do not give that liquid to somebody that cannot swallow. If they're having any kind of conscious issues that going in and out of consciousness, don't put that in their mouth. Don't let them take those. They have the consistency of a cream. They are a little thick, so be cautious of that. As an advance, you can give oral glucose gel to a patient with some low blood sugar. Um, I think it's crazy if you recognize it. You can check their sugar, but you don't want them to give D50, but they can give D5W. There's a whole realm of that. So know your local protocols. Gases, some agencies allow uh, nitrous oxide on their trucks. I know Birmingham Fire is the closest one that I'm aware of that has nitrous oxide. They see some very, very good usage of that, and they use it a lot. We know oxygen is there. We use oxygen. I mean, I can say you probably give it every single day to somebody. I've always said oxygen is the cheapest drug that you can give to somebody to have their own security that they're breathing fine. Well, you just spoke 500 words in a second, but you're having trouble breathing. You know what? I'm going to give you some oxygen. Is that helping? Oh, I feel like I can breathe. If you would stop talking for 10 seconds, you'd be great. So, and it says there that nitrous oxide may be administered by a national advanced EMTs. Nationally, it can be, but sometimes your agency may not allow it due to the particular med control doctor that you have may not like the use of it, but it can be given on the national level. All right, so routes, let's talk about this. So route of a drug administration affects the rate at which the onset of an action and the effect, the therapeutic response within that result. So choose the route of administration is crucial in determining the stability of a particular drug. So drugs are given for their local or systemic effects. We know that their absorption is the process by which that medication travels through the body until it reaches the bloodstream. Some external drugs administered along any portion of the gastrointestinal tract. We have our orals per PO, which is by mouth, that they do enter the bloodstream through the digestive system, and it can take up to at least an hour for them to be absorbed if it's taken PO. You have rectal or PR per rectum, and again, let's say no advance can give any medication administered rectally. The exception is dependent upon your protocol and or your medical director could potentially give you orders to give D50 that way. It's rare, but I've heard of it. So if your agency allows that, have fun. Parenteral drugs is administered through the route other than gastrointestinal tract, as in like your IV, or into the vein. For medications that need to enter the bloodstream pretty fast or immediately, is given by IV. Your interosseous or into the bone reaches the bloodstream through the bone marrow and requires drilling of the IO needle into the bone cortex. It is painful. I will tell you, it's very painful for a patient that is semi-conscious of having the IO inserted. A lot of times we do reserve this for those unresponsive cardiac arrest patients or some of those that are in extreme shock. Most of the time we use common IVs for children or adults, but you can give IOs in the humerus or in the femur, in the leg. But again, I'm gonna tell you, it's painful. I've done it multiple times to people throughout my career, and I can speak specifically of one. Up until the day she passed, years later, she still had a scar on her leg from where I drilled her. Subcutaneous injection, that is right there beneath the skin. The injection given into the tissue between the skin and the muscle. Given it sub-Q, that is generally absorbed more slowly, and they do have that longer lasting effect given it that way. That is a very big, useful way to deliver medications that cannot be taken by mouth as long as they do not irritate or damage the tissue of the particular area that you're giving it in. Pharmacokinetics pharmacokinetics meaning is the movement of drugs throughout the body. I should have said definition. So pharmaceutical properties determine a drug's concentration at the site of the particular action. So drugs modify existing functions of tissues and organs. Now, they do not give new functions to those tissues or organs, but in generally drugs cause multiple actions rather than just a single side effect. A drug action is the result of a psychochemical interaction between the drug and a molecule in the body, such as a receptor. Pharmacokinetics is once administered a drug through the 4 stages: absorption, distribution, metabolism, and excretion. Pharmacokinetics is the study of these 4 stages and the metabolism and action of that drug. So some principles of pharmacokinetics is to carefully consider those pharmacokinetic properties of a medication you're thinking about giving to the patient. So what's it going to do? How fast is it going to be absorbed? I need to know how fast it's going to be absorbed and distributed through the body. Should I give sublingual nitro, or should I put it on the absorb on the skin? Let's see. The onset and peak of a medication are generally related to the absorption and distribution. A minimum dose or concentration of a medication must be present at the certain sites in the body for a chemical to for the chemical to effect to take place. The duration of an action is generally related to a medication metabolism and elimination. So drug absorption is the passages of a substance through some surface of the body into a fluid and tissues. You have numerous variables effects of drug absorptions. Some small ones are nature of the absorption surface. What is the blood flow to the site of that area? What is the solubility of that drug? Its pH, the drug concentration, and then just the route of administration. Those are all things that can take place that may turn around and affect its ability. Biotransformation is many drugs are inactive when administered and only become active once they have been absorbed and converted into an active form in the bloodstream by a target tissue. Biotransformation is a chemical alteration that substance undergoes in the body. Primarily organ for biotransformation is the liver. If the liver is diseased, inactive, a drug's just not going to work. The liver performs synthetic reactions that yield inactive products or metabolizes that can be secreted by the kidneys and non-synthetic reactions. Mouthful. Pharmacodynamics is the way in which a medication produces the response we intended. So the pharmacodynamics, basically, that is the mechanism of action. This includes factors that may alter the intended response and any side effects or those unexpected effects that we see. Mechanism of action. To produce the optimal desired or the therapeutic effect, a drug must reach the appropriate concentration at its site of action. So if I'm giving an IO medication and it needs to go to the heart, we know that I'm drilling them 90% of the time in the leg, but it's going to get into the blood system. But think about how far it has to go. Versus me having a good IV in the arm, it's going to go faster. So you may not be able to get that IV and you may have to drill them, but that's okay. But we're trying to get that therapeutic drug in there without it breaking down. Drugs may produce some side effects locally, systemically, or to both areas. Local effects result from the direct application of that drug to a particular tissue. Medications cause their action on the bodies by 4 mechanisms. They may bind to a receptor site. They may change the physical property of a cell. They may chemically combine with other chemicals in the body, and then they may alter a normal metabolic pathway. Medications that bind to a receptor site are the most prevalent, particularly in our pre-hospital settings. Some cellular response can be wide-ranging depending on the chemical mediator and the cells being stimulated. Medication molecule must compete with naturally occurring chemical mediators and potentially some other medications that are within their body. Once the medication is bound to that receptor site, it initiates a chemical change that produces the expected effect that we want that medicine to take place. So drug response relationships. Once the medication finds that particular target tissue, it needs to accumulate to a sufficient concentration to produce this desired effect. So the drug response relationship correlates the amount of medication given and the response that it's supposed to cause. When it's administering a medication, you need to know the onset of action and the duration of action, and then the termination of action. So you're basically trying to figure out what its shelf life is within the body. When did this take place? What is the time it's going to take? How long are they going to feel good for? And then it terminated at this time. Like their pain started back. Onset, duration, and termination of an action affects the therapeutic index, obviously. The ratio of a drug's lethal dose for 50% of the population to its effective dose for 50% of the population. So, gives an indication for a medication's margin of safety. Each medication also has a biologic half-life, times it takes the body to eliminate half of the drug. Therapeutic threshold is the minimum concentration required to produce the desired response. A concentration lower than the therapeutic threshold will not induce a clinical response, but a concentration higher than the therapeutic threshold can be determined and possibly fatal. So there are many variables that influence medication interactions, but it's very important for us to know how medications affect patients and other medications that were previously administered. An interaction between medications occur whenever the action of a drug on the body are modified by another chemical substance. So another prescription medication we've talked about in prior, herbal or OTC medications, something in their particular diet, and anything to which a patient is exposed to. It's important to be aware of potential interactions of medications that are prescribed and those that the patient have been administering. So we've talked about this already. I think that we can skip this. So understanding the knowledge of what our medications can do and some of the other medications that the patient may be taking is just as important when we're getting ready to give a medication, because you're going to be like, well, that's a contraindication of this particular medicine because they're taking a diuretic. Well, I don't need to give them more Lasix because they're already on, So knowing those interactions is what we want to know in the field. This is very, very important. I am a very advocate of these rights right here. So medication decisions are often based on memory and frequently occur in the context of a stressful, life-threatening patient situation. Use these 10 rights of medication administration. Screenshot this, write this down, live by this, sleep on it, get it through osmosis. So we need to know that we have the right patient, the right medication, the right dose. We're going to use the correct route. It's the right time to give this, the right documentation and reporting. We did the right assessment. The patient has the right to refuse this medicine, the right evaluation, and the right patient education is done. These 10 R's are super important for us to know, use, and live by as advances when we're getting ready to administer medications. When the patient has the right to refuse, you have to explain to them what medication we're giving. Here's why. If they say no, like it may be a religion based that they don't receive blood. It's one tops off right top of my head. That's their right, even though they know that not receiving this can potentially cause death because you're not receiving this particular medication or the blood. It's their right to refuse that. So I'm harping on this. If you carry a clipboard, a book, or anything, these need to be written on there at all times for when you get ready to look at a medication and give this medication. Make sure that these 10 R's are done. All right, so I think she's had a bad reaction. So use the current reliable medication resource whenever administering potential unfamiliar medications. Some technical errors can be avoided by having your partner make sure that you have the right medication, it is the right dosage, Even if it's the brand new basic that just graduated school, have them look at it. It doesn't matter. You're teaching them something. Hey, I need you to check. Does this syringe say 2 cc's and I've drawn this medication in this particular one? Is that what you see? That right there will help you. Those things are very vitally important to make sure that you just check them. So evaluate your patient's medication, their allergy, and their hypersensitivity before each medication that is given. The Institute for Safe Medication Practices has developed a list of medication abbreviations prone to causing errors. In your book, you should see some important sources of error relevant to the pre-hospital setting. Mine says 1211, just not real sure what yours says. So be cautious. I'm not trying to scare nobody. It's just, have I given the wrong medication? Yep, sure have. Have I caused death to a patient due to the wrong medication? Nope. Have I got my hand spanked? Yep. I had to go back through medication administration with the particular agency I was with. Fine, perfect. And the thing is I owned up to it straight away. That's the reason why I never got in super duper trouble. I owned and said, hey, this was done. I gave this wrong medication. I was in a hurry. I asked my partner to grab it. I did not even look at it. I drew it because it was just this situation. But I effed up. I got my hand spanked. I got the tongue lashing, but I didn't harm the patient to where they couldn't come out of it. So now that's why I live by those R's. All right, so as an EMT, you may administer on the national level oxygen, glucose, glucagon, IV dextrose, IV fluids, epinephrines, the meter dosed inhaler medications like albuterol. You can nebulize medications such as albuterol, nitroglycerin in its spray tablet and paste form, nitrous oxide, naloxone, aspirin, and some others that are based on your protocols. Remember, study your protocols. You may administer or help administer these medications only under the following situations. Call med control. Just easy thing. Call med control. Just be like, hey, doc, I know I talked to you about 10 minutes ago. It's a different patient, but I just knew you wanted to hear my voice. I got a question for you. And just lay it out there. You're not asking to say that you're stupid. You're trying to get what you already know, but you're reiterating the facts. If they tell you, hey, look, I don't want them to take that for this reason because you're coming here and da 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 da, that's perfectly fine. But you did exactly what your local protocols they're allowing you to do, but you have questions about it. You're like, I don't think this is the right medication at the right time. I have a question. Call med control. They there 24/7. They don't get holidays. Well, they do, but they don't get those breaks. So being cautious is okay. Being cocky and confident are two different things. I made a mistake. I owned up to it. I learned from it. And again, that's why I've told you, I live on my medications by the R's. We call them the 5 R's. With the company that I'm with, they've reduced it down to 5 R's, but it's majority. It's the first 5 on the 10 R's. I do it every single time I give, and that's the reason why my doc knows and he gives me a specific order for certain medications. I read it back to him specifically, and he now does it. He emails me exactly what he wants, even though I just repeated it to him. He just knows how I am. He knows how I'm very particular about that. My protocols allow me to give certain medications without calling them, but I'm not doing it unless I talk to you. Just now, if it's a life or death, yes. But there's one like tetracaine that we give for debris in the eye. I will not use it until I call and speak to him. It's in there. I can do it all day long, every day. That's just part of me. I'm not doing it because I don't like eyes. I don't like dealing with eyes. But we 99% of the time always get calls for debris in the eye. That's every time we get people upstairs in my clinic. So I should be used to it by now, but I just don't like tetracaine. to me, it's kind of like a dentist. I despise a dentist as a medic, but it does a great job. All right, folks, that is the end of your lecture. I know y'all are excited. I know y'all are ready to leave me, and y'all are tired of hearing from me. Does anybody have any? I know y'all have questions, yes, but do y'all have any concerns or anything? All right, I'm just gonna tell y'all, if y'all don't have anything, y'all have a good night. See y'all Wednesday. Hope y'all have a wonderful. I will send those out. Hope y'all have a fantastic evening.